Good Wednesday afternoon. Thanks so much for joining us here on KVUE.com this afternoon, and of course all of our KVUE digital platforms today. I'm Brian Mays, and this afternoon we're hosting a special live question and answer session all about heart health in honor of American Heart Month. Joining us this afternoon, we're pleased to have Dr. Vivek Goswami with the Heart Hospital of Austin. Dr. Goswami, board certified in cardiovascular disease, nuclear cardiology, vascular interpretation, and internal medicine, among other specifics. Doctor, thanks so much for the time today. You were on our story last night. I know a lot of people are very pleased with the way that turned out. Thanks so much for your expertise here today.
Well, thanks for having me. I really appreciate the opportunity.
Let's talk about heart disease. We're going to get to that story. I want to show people kind of how it all worked with the Heart Saver CT. But heart disease is kind of a broad topic, isn't it?
It is. It's somewhat of a lay term. And I think, when we talk about heart disease being America's #1 killer, that really can encompass a lot of things. In theory, if you had a heart valve problem or if you had a rhythm problem, by its literal sense, I mean, that could be considered heart disease. But I think the implied underlying problem when we talk about heart disease being America's #1 killers, we're really talking about that cholesterol plaque that can build up in the arteries that give blood supply to the heart. And that could potentially lead to blockages, decrease oxygen to the heart. And those are things that lead to heart attacks, stents, bypass surgery, etc. So although heart disease in its literal sense can encompass anything related to the heart, I think what's really implied when we say that is that development of plaque that normally occurs as we age and get older.
All right, we're going to talk a lot about that, but I do want to talk about the story that we aired last night here on KVUE. Of course, American Heart Month is upon us. A good time now to consider your own heart health. For many, the first symptom of heart disease is a heart attack. Most people don't know they have a problem until it's really too late. At the Heart Hospital of Austin, there's an easy way, a really easy way to see if you have some of that risk that Dr. Goswami was talking about. It's called the Heart Saver CT, and I had a chance to experience it firsthand. Take a look.
These machines are the best that I'm able to work with at any of the facilities that I work at.
Courtney is the technician. She says they conduct on average between 15 and 20 of these heart screening x-rays per day here at the Heart Hospital of Austin. It's also known as the Heart Saver CT.
Go ahead and lie down on your back for me.
The procedure itself really couldn't be any simpler. You don't have to put on a gown. You don't even have to take off your shoes. You lay down on the machine on your back with your hands above your head. The technician will then attach 4 leads.
I'll try to put them where I don't have to give you too much of a wax job.
Now, there is radiation here. It's an x-ray after all. So you're in the room all by yourself. And this is also why it's not a good idea to have this procedure done frequently. Once you're moved into position, there are verbal instructions, 2 in fact. The first, hold your breath. This takes about 5 seconds.
Take a breath in and hold it.
Then about a minute later, another instruction to hold your breath again. This one lasts about 10 seconds, and that's it. Test complete.
All right, Mr. Mays, we are all done. You did a fantastic job for me.
Good. That was easy.
On a normal visit, you will wait a few days to get the results in the mail, as it takes the doctor's time to evaluate each x-ray. I was lucky enough to have Dr. Vivek Goswami there to show us exactly what my heart x-ray showed.
What we're essentially looking for is this cholesterol plaque that can build up in the arteries that give blood supply to the heart. When that plaque gets chronic or old, it can calcify, and these scanners are very sensitive for detecting that calcium in the heart arteries.
Now, I have a history of heart disease in my family. I take medication for high blood pressure and to maintain my cholesterol. I've got less than stellar eating habits and a few extra lbs, so I was a bit nervous.
This is your aorta, the main artery coming off of the heart. If you look here, so that's your left main coronary artery. So this is one of the major arteries coming off that actually gives blood supply to the heart.
That's sometimes referred to as the widow maker. You might have heard of this. Calcium buildup there can be deadly. Today, though, my report is a good one.
Not much going on here, which is a good thing.
Now, it's not magic, and quite frankly, it's not as thorough of a test as a coronary angiogram. That's where dye is injected into your heart's arteries and chambers for a closer look. That test is much more invasive. The heart scan I had is a great tool and is very good at detecting potential serious issues with your heart, or letting you know that for now, things look good.
historically with heart disease, I think we've had it wrong because we've been screening for the risk factors, not necessarily the disease. So that's why I consider this almost like a mammogram of the heart. So when people are feeling fine and they're in their 40s and everything's great, I think that is the high yield time to make sure we're not forming this stuff early, because if we can catch it early, there are things we can do to break the natural progression of disease.
Dr. Goswami, kind enough to join us once again here on the desk. Let's just get right to the nuts and bolts of what happens during this test. When you determine someone has plaque or the calcified plaque that is built up, what is the danger?
Yeah, so when we have plaque in our arteries, it could be non-obstructive 1 minute. So you can have, let's say, a 20% blockage, so 80% flow is still going through that artery, which would be fine. You could actually do any daily activity with 80% flow. But what can happen is, in an instant, that 20% blockage can get inflamed, angry, just really irritated, almost pop like a pimple would. And when that happens, that 20% blockage can go to 95% or even 100% in a period of seconds. And that's why you made a very important point in your initial comments, is that 60% of the time the first symptom of heart disease is a bad one, sudden cardiac death or a heart attack. So that person the night before is sitting there eating dinner with their family, they feel fine. The next morning, that plaque ruptures, goes from 20% to 100% in that instance. And therefore, if we're really serious about preventing heart disease, we can't just react to it. We have to get ahead of it and see who's forming this stuff early.
I love what you said in the story, in that we need to prevent it by doing things. You say it's a mammogram of the heart, which is, people have mammograms, colonoscopies. I've got one later this year. To prevent it is important because you don't really, like you say, know until it comes to the point of something drastic. Let me ask you, we got a bunch of good questions from viewers. I want to get to a couple of these too while we have you here. Gloria's in Round Rock. She says, in order to prevent having a heart attack, how does someone know they need to see a cardiologist?
Yeah, so it's a great question, by the way. So historically, oftentimes when patients finally make it in to see a cardiologist, oftentimes it's too late. They've already had a heart attack. They may have heart failure, defibrillators. They may be in and out of the hospital with recurrent symptoms. And certainly we want to see those individuals and make sure we can improve their hearts as best as possible. Really, what we should be doing is screening for this early and hopefully having a discussion either with your primary care doc or a cardiologist to prevent those things from happening. So oftentimes, I think we defer to the reaction of heart disease, stents, bypass surgery, etc. It's important that those things are important to temporize heart disease, but really putting an individual's balance in the most favorable balance possible is how we prevent a heart attack or premature cardiovascular death. I mean, 80% of all heart attacks are preventable. 4 to 5 cases of the leading cause of death in the United States could be prevented. So I think it's important to, especially if you're at high risk, to establish with a doctor that can help modify your risk factors and really empower the individual to make sure they're engaging in heart-healthy diets, regular aerobic exercise, avoiding things that could be bad for their arteries, etc. So I think getting ahead of it is really important, and I often like to see patients, sometimes people feel silly coming in to see a cardiologist if they're not having symptoms or if they're having a heart attack. That is my favorite time to see an individual, because we can have meaningful discussions, do things that are proactive to prevent those downstream consequences that we often see when it's too late.
It's so proactive. This test is really, really part of that. Teresa on Twitter asks, how do men and women present with heart disease differently, if at all? She's heard the signs of heart disease and heart attack differ depending on whether you're male or female.
That's another great question. So, first of all, the classic symptoms of heart disease are often described as a chest pressure, oftentimes a heaviness, an elephant sitting on the chest. People can sometimes use a fist to describe the symptoms. Doc, it hurts right here. I mean, we're trained that should really open our eyes. This may be the heart. Oftentimes the symptoms can move to the left shoulder, the jaw. There could be associated shortness of breath, nausea, vomiting, sweating. These are very classic symptoms of a heart attack or a heart problem. Women, in contrast, can oftentimes have very subtle or not so classic symptoms of heart disease, which really makes it somewhat of a challenge, because oftentimes the individual themselves won't recognize that those symptoms are actually their heart. So, for example, sometimes women can just present with fatigue or just throat discomfort, jaw discomfort, back pain, really vague symptoms that maybe the individual doesn't realize, hey, this could be my heart. And unfortunately, the other thing it could lead to is when they finally do seek medical attention saying, look, something's wrong here, women are more likely to be misdiagnosed as having things like heartburn, anxiety, because the presentation is not so classic. So I think we have to have a very, very low threshold. Again, heart disease, leading cause of death in men and women, and we really need to appreciate that the way that presents can be very, very different. We have to have a low threshold of making sure we're not missing something dangerous. That atypical presentation can oftentimes delay time to very critical treatment. So when an individual's having a heart attack, every minute matters, because every minute that goes by that we don't restore blood flow to the heart, there's part of the heart that's dying and the mortality increases. So delaying time to critical treatment is often one of the mechanisms for which we know that women do worse when they have a heart attack, even when we adjust for things like age and comorbidity. So I think appreciating our risk and knowing our bodies and knowing that if we're having any symptoms that we haven't experienced before, keeping a low threshold of getting checked out is important. And knowing your risk on the front end can help as well.
You mentioned throat issue, a throat pain. What would cause that to happen in someone? And heartburn, for instance. How do you know the difference? Is there a way to know the difference?
It is a bit of a challenge, because oftentimes the same nerves that can sense heart pain can refer to different areas, and everyone's pain can be different. So what we like to do is evaluate any symptoms that could be related to an individual's heart. And once an individual's been satisfactorily checked out, if they tend to have kind of chronic or recurrent symptoms of the same nature, something that they've always had, and we've deemed that non-cardiac, it's probably not your heart. And we can look at other things like heartburn or esophageal spasm or other issues that can cause similar symptoms. But really, just because you've been checked out, if you develop new symptoms or if symptoms tend to worsen or progress, I think everything gets zeroed out and so much should get evaluated again. So it's really hard to tease out, especially when we have ongoing symptoms.
Sure.
But really, I think it's amazing. People know their bodies really well, and if these symptoms change or if they're new in any way, certainly the only thing you're trading is a little inconvenience by getting checked out. So always err on the side of caution.
And we should say again, we're not trying to scare anybody. We're not trying to, alarm you. Is this throat thing something I should be concerned about? But it's good to be aware, especially when it comes to your heart. All right, I've got another one from a viewer, Jaime in Austin, in relation to the procedure. I guess you call it a procedure, the HeartSaver CT X-ray that I had. Sure. He had an aortic valve replacement at the age of 56. Had some issues as well when he was younger. Is this something he should look into, or maybe should he go another route?
So I think what Jaime probably had is a little bit different. So about 2% of the population, so 1 out of 50 people are born with 2 aortic cusps instead of 3. It's called bicuspid aortic valve. And oftentimes right around the 4th or 5th decade of life, these valves tend to wear out faster, become narrowed, and we have to replace them right around his age. And when you have a bicuspid aortic valve, a small percentage of those people will have what he's described, which is a coarctation, almost like a kink in the aorta. Usually that presents with high blood pressure, especially in the upper extremities. And while a CT scan really is one of the best tests for identifying a coarctation, in the case of ruling out a coarctation, we really want a CAT scan with contrast. So it would be a CAT scan, but I wouldn't necessarily suggest the type of CAT scan that you had for that particular situation. So that would be more of a CT angiogram. So there's a lot of different CAT scans. It gets confusing. The protocol that you had is a protocol that doesn't require any contrast. It's obviously very quick and simple because all we're looking for is that calcified plaque. There's other things that could be of interest for which we use CAT scans, and each one of those would have different variations of the protocol, including one that was looking for a coarctation.
Let's talk about the Heart Saver. I got the results yesterday, in fact, from you were there, kind enough to go over my results right there in person, which isn't normally how it happens. You go a few days in the mail and then you get the results. My score was 0, which is good. Can you kind of explain to people what you're looking at when you see those scans, you and the other cardiologists that examine the results, and then what that score means on those results?
So basically, when this cholesterol plaque that could potentially build up in our arteries, when it becomes old or chronic, it calcifies, much like other things in the body. So the scanner, the CT scanner, is very sensitive for detecting that calcified plaque in the arteries. And the more calcium we have in our arteries, the higher the score we get on that test. The higher the score we get on that test, the higher the risk. The lower the score, the lower the risk. So a perfect score is 0 because we're not seeing any calcium. So congratulations, that was your score, right? But really that score, I mean, we've seen scores in the 3, 4, 5,000 range, really. So we want to know, A, does an individual have any calcified plaque, and if so, how much? And then we correlate that to an individual's age, because to some degree, if we live long enough, we will form this plaque in our arteries. What we're trying to exclude is premature formation of this calcified plaque, because unfortunately that's what's leading to all this heart disease death. So we're really trying to catch people on the early side of that bell-shaped curve. So that score basically correlates nicely to an individual's risk. In crude terms, any score less than 100 is considered low risk. 100 to 400 is considered intermediate risk, and greater than 400, we know those individuals are at higher risk of developing a cardiac event in the upcoming years. So it's a good way to risk stratify, and anytime we see a patient, we don't want to use our x-ray vision. We want to say, how worried are we about this individual potentially having a heart attack? And direct visualization of the plaque is a very, very key component to determining that.
I mentioned in the story, I do take cholesterol medication, blood pressure medication, not in as good a shape as I used to be. What kind of people are you targeting? Not targeting is not the right word. What people should be looking into something such as this if they're concerned a little bit maybe about the same things that I was dealing with? What kind of factors make you want someone to come see you?
So certainly anyone that has a strong family history of heart disease, especially early heart disease, if an individual has risk factors including high cholesterol, high blood pressure, maybe diabetes, if they smoke, these are all risk factors for heart disease. But importantly, irrespective of those risk factors, we can still develop heart disease. Those risk factors increase the likelihood of developing plaque, but they don't necessarily exclude the fact that you're not forming any plaque if you don't have any risk factors. So, as we mentioned when we're at the hospital, I think common things are common. If we know heart disease statistically is the thing that's most likely to take us out, it's hard for me to argue why every adult shouldn't at least at one point kind of see where they stand in terms of development of plaque.
How long has this specific scan that I had been around, and where do you see it going in the next few years? Will it be advancements?
I believe so. So, it's been around for years. I mean, the technology is certainly not new. I think the data around the prognostic value of the scan has really, really improved over the last 10 or 15 years. When I was in training, 15, 20 years ago, it was not common practice to use a calcium score for risk stratification. That's changed over the last 10 years, and I think that's changed for the better. I mean, you made the analogy about mammograms, and if you think about it, we're routinely screening for breast cancer with mammograms because we know that by the time an individual has symptoms of metastatic breast cancer, we've missed an important window, right? If we can catch that early, we could do things to break the natural progression of disease. We know with colon cancer, by the time someone has symptoms of metastatic colon cancer, we may have missed an important window. So we screen for it early with colonoscopies. Yet historically, we've never screened routinely for something that's more likely to get us than breast cancer or colon cancer. And we know that if we wait around for symptoms, oftentimes it's too late, right? So I think we've really had this wrong for a number of years, and I really, really like the direction that more and more people that I talk to, I ask them, hey, have you ever had a calcium score? Have you ever screened yourself for heart disease? And more people are saying yes to that question. I really like that. It still amazes me the amount of people that have no clue where they stand. Do you have any plaque in your arteries, yes or no? If so, how much? I think it's a very important question that every individual would want to know, including their doctor, right? Let alone the patient.
Absolutely. Dr. Goswami, again, thanks for your time. I've got a few more questions. Do you have a few more minutes?
Oh, yeah.
Okay, let me ask you this. I'm not trying to make this about me, but I'm the example in the story. So my score was 0. So am I somebody that now needs to, in 5 years, in 10 years, go back and do it again? What's the risk factor for someone that has the test and might score well? Are they in the clear, or do they need to be concerned in a few years from now?
Yeah, so I think that's another great question. So clearly, if you're going to do the test, you want the score that you received, which is 0. And if you're going to have a score, you want to be as low as possible, because as we mentioned, the higher the score, the higher the risk. So the fact that your score is 0 puts you at very low risk today in 2022. And really the focus should be, how do we keep that low risk 5 years from now, 10 years from now, 20 years from now? So, in addition to optimizing, diet, aerobic activity, making sure your risk factors are under control, I think ongoing periodic screening is of value, because hypothetically, if say 5 or 10 years from now, you were to have objective evidence of plaque, depending on how much there was, that may prompt someone to be maybe a little bit more aggressive with your treatment. It may prompt you to say, maybe I need to improve, my aerobic activity, etc. So I do think there's some utility when you're young, if you have a calcium score of 0, to do some ongoing surveillance screening as time goes on. Most people that are under the age of 50 won't have any calcified plaque. So what you're basically proving when your score is 0 is that you're not forming premature vascular disease. But I think it's too early to say that you're not a plaque former. Now, if you contrast that with someone that's, say, 75 years of age and their score is 0, I think it becomes less relevant for that individual to get serial screening. Typically, if you make it 75 years without forming any plaque, you're probably not going to start forming this plaque between 75 and 80, right? So the answer to your question in terms of, do you need a follow-up study, it really depends on the result. So if the result is 0, I think there is some utility of doing a repeat scan in the future, especially if the individual's young. Once the score is positive, so once we're identifying plaque, especially if it's premature relative to the person's age, there really becomes less utility for doing serial scanning going forward, because that individual, the test has done its job. It's identified them as being of higher risk because they're forming the plaque prematurely. Those are individuals we're going to do surveillance, maybe stress tests, etc. Those are individuals we're going to aggressively treat risk factors. And that's not going to change based on the results of subsequent studies. So it becomes less useful to do a follow-up study in that scenario. So it's not a one-size-fits-all on who needs what going forward. It really depends on the result of the test and the age of the patient.
Since we've got you here, I'd love to ask you a couple of questions about the heart and COVID-19, and as it relates to not specifically what I had done, but people that are concerned about myocarditis, things that might affect the heart, that maybe this scan, I don't know that it would increase or decrease anything as far as the plaque or calcium buildup. But have you seen any correlation between someone that has suffered from the virus and their heart in your practice?
We certainly have, and that's been true for a lot of superimposed infections historically as well. So let's say an individual has less reserve because they've had a prior heart attack. Let's say their heart is not squeezing as well as it could or should. Maybe they suffer from chronic heart failure. Once you throw a superimposed infection, especially one that may focus on the lungs or target the lungs, that individual's reserve is a lot less than someone who may not have heart failure, and therefore the chances of having a negative consequence, whether it's respiratory failure or pushing their heart failure back into an area where they have to be hospitalized, etc., unfortunately that goes up. So we're seeing that. We are seeing some evidence of myocarditis as well. It's relatively rare, but anytime there's infection and anytime there is a inflammatory state in an individual's body, it can really cause inflammation of the heart, and that can cause the heart muscle cells to weaken. A lot of times that's reversible, and unfortunately a lot of times it's irreversible as well. So we're seeing an increased risk of myocarditis, and some people are even saying that COVID should be considered more of a vascular disease instead of a respiratory disease, because one of the big complications, as you know, Brian, is clotting. So we're seeing a lot of clotting throughout the arterial and venous systems. It's one of the mechanisms for why we're seeing increased stroke. And obviously the clotting cascade is very important to us at baseline, because when we're talking about a heart attack, when those plaques rupture that we talked about earlier, these platelets come and attack those plaques, they form a clot, and mechanistically that's what causes a heart attack as well. So there is a lot of kind of overlap in terms of COVID-19 and what we're seeing cardiac-wise, certainly.
Finally, are there symptoms? I know this is such a hard question because we're so early with this disease.
Yeah.
Are there symptoms when myocarditis is present? Are there things, telltale signs that parents maybe has a young son that has the disease or had COVID, and is there something they should be on the lookout for?
Yeah, sure. So, I mean, when we talk about the inflammatory process, myocarditis of the heart, especially when it involves a weakened heart muscle, if the heart can't pump enough to satisfy the metabolic needs of the body, typically that manifests with shortness of breath. We get a backlog of fluid or pressure on the lungs. Oftentimes, exercise or activity intolerance is a real telltale sign. So if all of a sudden your child or one of your family members was able to exercise or do things routinely, and now they've had an abrupt change in their exercise tolerance, that could potentially reflect an underlying cardiac issue.
Back to the scan I had. I noticed when I went in, there is a monitor that shows my heart rate. You could see, and mine was pretty high. I was a little nervous. What does a heart rate say about your either risk for heart disease or long haul COVID, or are there things your heart rate can tell you? Is that a concerning metric as far as the heart is concerned?
It's an interesting metric. I'll tell you, first off, for the CAT scans, the lower the heart rate, the better for us, because the slower the heart rate is, the better we can image the heart, right? It's hard to take a picture of something that's...
So I've made it hard on you.
Yeah, but fortunately, with your particular type of scan, the Heart Saver CT, because that calcium blooms, we actually don't need the heart rates as slow as we would for other type of protocols. So that's par for the course, and that's fine. It didn't compromise the quality of your study at all. I think it's important to know that heart rate's a very dynamic thing, right? So there's a lot of things that go into your heart rate. If you're stressed, if you're dehydrated, if you have a fever, if you have a clot, if you're anemic, if your thyroid's overacting, all these things can affect your heart rate. So oftentimes, in the case of an elevated heart rate with a normal rhythm, it's the heart's manifestation of a separate issue. It's not typically a primary heart issue. Now, it's a much different story if the heart rate is elevated due to an arrhythmia, right? So if people have atrial fibrillation or SVT, that's a primary heart problem. But if the heart rhythm is normal, the heart rate's elevated, usually that's the heart's manifestation to some other systemic issue. So we don't want to focus on the reaction. The treatment for that is to treat what's causing the elevated heart rate. When we talk about the opposite scenario, like a slow heart rate, for example, that's usually dependent on an individual's vagal tone. So a vagus nerve is the only nerve in the body that could slow a heart rate. And a good example of increased vagal tone would be runners. So these runners have very low resting heart rate because they have high vagal tone. So that's why they say a resting heart rate, you must exercise a lot, because the more we exercise aerobically, the more we increase that vagal tone, which decreases the heart rate. So that's in young, otherwise healthy people. In elderly people, if the electrical system's starting to become inefficient or burnt out, that can result in a pathologically slow heart rate. That's no longer an athlete's heart. That's a slow heart rate due to the electrical system burning, and those are the individuals that we consider for pacemakers.
So a clogged artery wouldn't cause a slower heart rate?
Typically not. There are some exceptions where if there's a clog in the artery that leads to the natural pacemaker of the heart, so the clogged artery is decreasing blood flow to the actual electrical circuit, that actually results in certain types of heart block. I think that's the exception, not the rule. So there's an electrical system of the heart, there's the plumbing system of the heart, and oftentimes they're independent of each other, with some exception.
We've got about a minute and a half. Let's finish by talking again about the Heart Saver CT. People are watching now, might be thinking about trying this, getting an appointment.
Sure.
How do they go about doing that? What's the best way? Should they call the office? Should they online? How's the best way for someone that's watching now to get this test done?
Yeah, I mean, I think, so we try not to make it hard for people, right? So you can go to the St. David's website, the Heart Hospital website, and get information on how to sign up for the Heart Saver CT. It's very easy, as you know, and there's no contrast or IVs or anything involved. I think think it's important to highlight the fact that even if you're not in the wheelhouse age of having a heart attack, which is maybe 60s, 70s, etc., when people have heart attacks in their 60s and 70s, it's not because of what they did in their 60s or 70s. That process actually starts much earlier on and manifest in their 60s and 70s. So I think just like anything, the earlier we can identify the substrate, the much more likely we are to break the natural progression of disease. In the case of heart disease, it's no different.
I like the way you said it. It's proactive treatment.
It's proactive treatment. That's
It's
exactly
great thing.
We should do more of that.
Doctor, thank you so much. I threw a lot of questions at you. I appreciate you answering all of those.
Well, I appreciate you covering a very important topic, not just for us, but an important topic for really all of Central Texas.
Absolutely. We thank you. Thanks for your time.
Thanks, Brian.
Thanks for joining us for this special question and answer with Dr. Vivek Goswami, and we hope this helped you understand a little bit more about the importance of American Heart Month and why taking steps to prevent heart issues now might save you a lot of trouble in the future. We'll see you tonight on KVUE.